Hello, and welcome to the newest lecture on DNA viruses. There's a couple of people here who want to say hi to you before we get started.
Hello. Hi, I'm Reese, Mama's son.
Mhm.
Hi, I'm Cora, Mama's son. Daughter.
All right, get out of here, you guys. Let me
No,
record.
I'm not getting out of here.
Go. Let me record, okay?
Hug.
Give me a hug. All right. Okay, bye.
Bye.
Go on.
So long, suckers.
Okay. All right, today we're covering DNA viruses. A few things to remember. We are going to talk about herpes viruses, not all of them today, but most of them. We'll talk about adenovirus, parvovirus, and hepatitis B virus. So as we go, remember that viruses don't really produce toxins or virulence factors in the same way that bacteria do. Most of the disease we see due to viruses is due to their replication and lysis of cells, or due to the host's immune response to those viruses. So host-mediated pathology. All right, so let's start with our mini case study. So we have a college student who's presenting to his primary care physician with a sore throat, high fever, and a skin rash. All right. So on exam, his pharynx is noted to have a gray-white exudate, so some sort of pussy, slimy lining on his throat, along with a distended abdomen. And that distended abdomen results from an enlarged spleen and liver, right? So we've got a few things: high fever, sore throat, that sound familiar, but now we have an enlarged spleen and liver, which is a little different from anything we've covered before. So blood work demonstrates lymphocytes containing abnormally large nuclei perforated with holes, which is a hallmark of this particular condition. So while our initial symptoms sounded familiar, this is a little bit different. And down here is a picture of those abnormal lymphocytes. So you can see they're irregularly shaped. They're not all round. This is the enormous nuclei within these guys. And you can see the tiny little white holes within those nuclei as well. So these aren't normal. They don't work quite right. So based off of this, your question is, what's this patient suffering from? And how do you think he contracted it? So if you want to pause here, think about these two. What diseases do you know of that pass through college campuses that start with a sore throat and a high fever? And how do those tend to pass from student to student? Right? We'll come back to this in a little bit when we start talking about which virus causes this disease. All right, so today, quite a few learning outcomes. These are pretty specific, should be good for helping you study. So by the end of this lecture, you should be able to identify the sites of latency for the different herpes viruses. And you should be able to understand how the genome is maintained in that latent state. You should be able to describe the major diseases associated with human herpes viruses, to explain the consequences of human herpes virus infections of a fetus or a neonate, identify the major diagnostics of herpes virus infections that are mentioned in these slides. There are others. You only need to know the ones that I'm going to mention. So things like heterophile antibody, owl eye inclusions, downy cells, and the atypical lymphocytes like you saw on the last slide. I also hope you can identify the different diseases caused by adenovirus and parvovirus, and the populations who are most at risk for those viruses. And finally, understand how hepatitis B is transmitted and complications that can arise from hepatitis B acute and chronic infections. All right, so let's get started. First, we're going to talk about the herpes viruses. These belong to the family Herpesviridae, and there are quite a few of them. They are enveloped double-stranded DNA viruses. They have a linear double-stranded DNA genome that puts them in Baltimore class 1. They have an envelope, and their genome is packaged in an icosahedral capsid. So here's a nice electron micrograph where you can see all of the different glycoproteins that come out of the envelope. Here's our sort of cartoonish diagram where we have our genome on the inside surrounded by a nice icosahedral capsid, and our envelope containing all of the glycoprotein spikes that are necessary for attachment to the cell. Now, this envelope doesn't sit really close against the capsid. In fact, it can be really big. So I really like this electron micrograph because it kind of shows us how envelopes can be pleomorphic and can take on a lot of shapes. So we've got our capsid in here, and this giant line that we see around it is the viral envelope. Now, this envelope comes from the host nuclear membrane. So these viruses replicate within the nucleus. They carry out biosynthesis, assembly in the nucleus, and they bud from the host nuclear membrane. In the grand scheme of viruses, these are actually pretty large. Their genome encodes for 75 proteins, which does not sound a lot when you think about what you're learning in genomics and how many genes and proteins get made. 75 is a lot for a virus. Remember, flu makes about 10. Ebola makes 7 or 8. So 75 is quite a lot. Now, the different antigens that they have, particularly these glycoprotein spikes, and a few other antigens that they make on the inside, are what allows us to differentiate between the different types of herpes viruses, and that allows us to look at serology to determine whether a person has, human herpes virus type 1 or type 2, and so on and so forth. So there are 8 different members of the Herpesviridae, and there are 2 sets of nomenclature. So there's the common names, which are shown on the right side of these double colons. These are the ones that you've probably heard the most, like herpes simplex virus type 1 and type 2, Epstein-Barr virus, varicella-zoster virus. So these are the common names. At some point, someone decided we needed to rename all of these and give them a consistent nomenclature. So they also have names like HHV1 and HHV2. So that means human herpes virus type 1, which is the same thing as HSV1, herpes simplex 1, and human herpes virus type 2, which is the same thing as herpes simplex virus 2. There is a really good chance that at some point you're going to need to know both of these sets of nomenclatures. But for me, if you just pick one and stick with it, that's fine. I know that HHV5 is human cytomegalovirus, so pick one of these nomenclatures and stick with it as we go forth. Now, we break these viruses up into different subfamilies depending on the type of diseases they cause and where they undergo latency in the human host. So the alpha subfamily are the ones that cause blisters, like our herpes simplex viruses and varicella zoster, which is what causes chickenpox and shingles. Our beta subfamily.
Love you, Mama.
I love you too, buddy. Our beta subfamily causes rash and mild colds. So we've got human cytomegalovirus, roseola virus. And then our gamma subfamily are the ones that can cause cancers. And they include Epstein-Barr, which is human herpes virus type 4, and Adenovirus, which no one uses that name. We generally call it KSHV, or Kaposi's sarcoma-associated herpes virus. So it causes this very rare type of cancer that we really only see in AIDS patients. So we will talk about this one when we talk about HIV. But we'll go through most of these today to some degree or another. Now, what's really interesting to me about the herpes viruses is that during the lytic stage, they infect one type of cell. So they're going to attach and enter via fusion with the cell membrane. So here's a picture of our herpes virus. This outer ring is the envelope. This is the DNA core and the capsid here. They attach at the cell membrane and fuse, and then they release that capsid into the cytoplasm, where the capsid is then detached. The capsid in the genome traffic to the nucleus. The DNA is released from the capsid at the nucleus. And then biosynthesis and assembly largely takes place in the nucleus, except for translation, of course, which is going to take place on our ribosomes. So they assemble in the nucleus, they then bud from the nucleus and acquire their envelope from the nuclear membrane. They undergo this lytic cycle, all of this stuff, in one type of cell and usually undergo latent cycles in different types of cells. So there are a few exceptions, but by and large, they have different sites of lytic and latent infection. So really quickly, let's review what it means to have a latent infection. So if you look at the graph down here, on our x-axis we have time, and our y-axis we can think of this in terms of both viral load, so how much virus is in the body, and we can also think of it as our patient's symptoms. So we'll see a correlation between these two. So when our patient initially gets infected, they have a nice acute infection where we'll see things like fever blisters, if we're talking about a herpes simplex type virus. Then the virus will undergo latency, and for an indeterminate period of time, there will be no symptoms and no new virus being made. So no viral proteins, no new viral genomes, no new assembled and released viruses. That's what latency means. The virus is still there, but it's dormant. It's not doing anything. And then, for reasons that we still don't fully understand, the virus becomes reactivated, and we have a recurrence of symptoms that correlates with a recurrence of viral replication, of lytic replication. Now, usually these recurrences are not as severe as the initial acute infection, and that is in part due to the presence of viral-specific antibodies and memory T cells that are going to help to reduce duration and severity of infection as subsequent reoccurrences happen. All right? Okay. So our human herpes viruses 1, 2, and 3. So that's herpes simplex 1, herpes simplex 2, and varicella zoster virus. They are lytic in epithelial cells, so they cause blisters. Think about fever blisters or chickenpox, but they go latent in neuronal cells and in different parts of our body, actually. Human herpes virus 4 is lytic in B cells and in the oral epithelium, and it undergoes latency in B cells. Human herpes viruses 5, 6, 7, and 8 are generally lytic and latent in lymphocytes. So this is kind of our exception to this occurring in different cycles. These all occur in some form of lymphocytes. Human herpes virus 8, which causes a sarcoma, is latent in B cells. All right? So various areas of the body where they go latent, and various areas of the body where they carry out their lytic infections. Now these viruses all have latency as what we call episomal latency. So these viral genomes do not get integrated into the host genome. They are actually carried in the host nucleus as a separate piece of DNA. Now, often these pieces of DNA attach to the host chromosome via some sort of viral proteins that allows them to just kind of stick there during mitosis and get passed on. And usually there are multiple copies of the viral genome that's hanging out. So in latency, we have viral DNA in the cell, but it's not being transcribed, it's not being translated, we're not getting new viruses being made. Okay, so let's talk about the herpes simplex viruses. So as you can see in this picture here, they cause blisters, right? Think again about chickenpox, fever blisters, and those blisters are fluid-filled, and within that fluid is just a ton of virus. So these are highly contagious. So these viruses get spread by direct contact. So one of those fever blisters full of fluid coming direct contact with someone else, or indirect contact, like drinking after someone who has an outbreak of oral herpes at the moment. These fever blisters are generally caused by HHV1, also called herpes simplex virus 1. Cold sores, fever, blisters are what we term them. It's estimated that up to 90% of the population is actually infected with this virus, but it's a much lower percent that actually has a recurrence and experiences fever blisters. HHV2, or human herpes simplex virus 2, causes genital herpes, right? That's the more infamous one. About 90% of people who are infected with HSV2 are asymptomatic, so they don't have symptoms of herpes virus infection. And the other 10% do, and they can have recurrences of infection as the virus gets reactivated over time. I apologize for the shutting door. My son just left the room again. So human herpes virus 2 can be an issue if there's a neonatal infection, and it can be about 60% fatal in those cases. So this usually occurs when a child is born to a woman who received a primary HSV infection during pregnancy. So she was seronegative before she gets infected during pregnancy. There are no maternal antibodies to protect the baby, and the child contacts the virus as it passes through the birth canal. So this image here is showing an infant who was born with herpes simplex virus infection. This classic cigarette burn pattern, so you can see these marks on the child's head and near the eyes. These lesions can be there at birth if it is an infection that occurs in utero. That's really rare, but they often develop them 1 to 2 weeks after birth when the virus has had time to replicate. And again, we're talking about an infant with an underdeveloped immune system and without maternal antibodies being present in the child in utero and during breastfeeding. This can be a very, very severe infection. Again, 60% fatality. Even those who do survive often have some sort of long-term neurological sequelae due to inflammation and viral replication. Some additional things that we don't really think about when we think about herpes viruses, or they can cause eye infections if they get in your eye. This can cause keratitis, corneal scarring, and in very rare cases, people, not just neonates, but even adults, can develop herpes simplex encephalitis, where we have now infection in the CSF and in the brain, and our patient can develop pretty severe encephalitis. Okay, so let's look at latency. During an infection with one of these herpes viruses, herpes simplex 1, herpes simplex 2, or varicella zoster virus, which we'll talk about next, the primary infection occurs in these epithelial cells. So the virus attaches and gets into our epithelial cells where it replicates, makes new viruses, and we get blisters at the initial site of infection. Now, some of these newly made viruses then leave the cell and attach to and get into sensory neurons. So they get into the sensory neurons that innervate the site of infection. So those that innervate the skin of the lips, or the skin of the trunk, or the skin of the genitals. And in these neurons, they undergo retrograde movement. So they move from the end up to the cell body. And that is where they're going to go dormant. So this viral genome gets into the nucleus. They're maintained episomally. They are not making viral proteins. They are not making new viruses. And because they're there, they never go away. Because that genome is maintained episomally, we don't have any drugs to treat viruses in a latent state, right? We can't kill off all of these neurons. And so once this virus has gone latent, it's there for life. You cannot get rid of it. when reactivation occurs, and again, we don't really understand what causes reactivation, but now our viruses are going to begin to make some new proteins. They're going to make new capsid proteins. They're going to this time move down through our nerves, release into those epithelial cells that are innervated there, and begin the lytic cycle over again. Okay, so lytic cycle only in the epithelial cells. They move to the cell body of the nerves where they undergo latency, and upon reactivation, they move back down those nerves and start a new infection or a new lytic cycle in those epithelial cells. So HHV1 undergoes latency in the trigeminal ganglia. So the ganglia kind of like in the middle of the head. And so when it reactivates, it travels back down those nerves to the lips again, right? So this sort of the nerves that innervate the lips go to the trigeminal ganglia where HSV1 undergoes latency. For HHV2, or our genital forms of herpes virus, the virus goes latent in the sacral or dorsal root ganglia at the bottom of the back. Right, again, this makes sense if you think about it spatially. It's going to go to those dorsal root ganglia there near the pelvic region. Right, so again, reactivation, they travel back down those neurons to the initial site of infection. We don't really know what causes reactivation. There are some correlates, like people notice that they tend to have a reactivation and get cold sores when they're stressed out, when they have had too much UV sun exposure. But despite years of work, we understand the shifts, the genetic shifts that the virus goes through, but we don't really understand at the physiological level what causes reactivation. There are a few virulence factors for these particular herpes viruses that are really important in their disease manifestation. So they inhibit PKR to downregulate antiviral responses. They also inhibit apoptosis of neural cells, right? That's good because you want to keep your site of latency alive. And they also inhibit apoptosis of the epithelial cells, which again is good for the virus because it allows them to make more virus in that cell before the cell dies. Okay, for these three particular viruses, excuse me while I take a drink, we can diagnose them in a number of ways. So if there's extensive CSF involvement, we can do PCR to look for viral genomes. It's also pretty easy to do serology for monoclonal antibodies. Do we have antibodies for HSV1, HSV2? We can also take a smear from the lesions and look for these giant multinucleated cells, right? So here's our giant cell. It's got a whole bunch of nuclei packed into this one surrounding cell here, whereas over here we've got a normal cell, and over here we have a normal cell, right? So we look for these inclusions, or these multinucleated cells. That's typically a sign of a viral infection. But often it's just going to be, excuse me, a clinical diagnosis based off of what these lesions look like on a patient who comes into your office. We do have a lot of drugs we can use to treat HSV1 and HSV2, but to be really effective, a person needs to take these daily, both when they're in a latent state and when they have recurrence or reactivation of infection. If you stop taking these, that's often when a person will have a recurrence occur. So the ones that are typically prescribed are acyclovir, or some of its derivatives or cousins like valacyclovir, famciclovir, ganciclovir is another one. These all are useful in decreasing the spread of disease from one person to another. They decrease the duration of active disease because they're nucleoside analogs. They prevent viral replication. And when they're taken during the latent state, they prevent the frequency of recurrence. So as soon as the virus starts replicating again, these drugs will shut it down and even though a reactivation has occurred, you won't necessarily see disease. So it decreases the frequency of recurrence. But again, for this to really be useful, they have to be taken daily. If you only take it during active disease, it will decrease the duration. But only taking it during active disease won't do anything to decrease the frequency of recurrence. Okay, the very closely related to that, to the herpes simplex viruses, is varicella zoster virus. You guys know this because of the diseases it causes. One is chickenpox, which its like sciencey disease name is varicella. This usually happens in children, and this is what you get during the primary infection, so that initial acute stage of infection. And it's these itchy, rashy, fluid-filled lesions that tend to be on the trunk of a child. They can also go up onto the face, out to the arms, the upper thighs. Usually they're there on the trunk. Most of you guys will not have chickenpox. A lot of you were vaccinated against chickenpox when you were a child, and you're very lucky. I think I missed something like 2 weeks of kindergarten or first grade because I was out with chickenpox and was miserable the whole time. Where in like your grandparents' generation, where it's more of an issue, and in my generation it will be in hopefully many years, is shingles. So shingles has the disease name zoster, or herpes zoster. You've probably heard that before. And this is what happens when chickenpox reactivates in adults. And now the manifestation is very different. And so instead of having this diffuse spotty rash, shingles occurs on the torso, usually around the side. Like you can see, here's our person's belly button on the side like this, and it forms these huge blistery areas. It's very painful in our adults, and it usually doesn't cross the midline. So when it reactivates typically only to one side of the body. So this can be spread by direct transmission from either coming into contact with blisters that a child has or blisters that an adult has as shingles. But what causes this one to spread really quickly through unvaccinated children, and what happened prior to the vaccine, was that like half of a class of kindergartners would all come down with it because it's spread by respiratory droplets. So it can replicate in the upper respiratory tract, and even though it doesn't cause pneumonia or anything like that, you cough it up and you spread it on to new people, and then travels to those regional lymph nodes, gets into the T cells and causes viremia, and then from those T cells makes its way to the epithelium in our primary chickenpox infection, right? So then it does go latent in sensory ganglia, again in the dorsal root ganglia usually, and will reactivate there in the epithelium of the trunk. Okay, so just kind of another way to look at this, to give us a kind of, to put it into like body perspective. The initial infection that can be diffuse is going to move up the spinal nerves until it reaches the ganglia there in the spine. So then the virus is going to go latent in that nerve cell body again. So our little viruses, our little red dots in here that you can see. And when it reactivates, it's going to move down these spinal nerves. You see this up here, it's moving down these spinal nerves, and it's reactivating there at the area where these nerves innervate. And again, this one can be pretty painful. It's usually not itchy so much, but it can be pretty painful. Since it's interfering with these nerves, you can have shooting pains up and down that side of the body, even like into the face. And you can have shooting pains up into the face and the extremities, even without having those lesions at those sites. Right, so similar to our simplex viruses, where it moves up into the spinal nerves and then moves back down and reactivates. So usually for chickenpox or varicella or shingles, it's a clinical diagnosis. You look at it, you listen to the patient's symptoms, you know what it is. You can treat pretty easily. And in adults, particularly if they're older and they're experiencing shingles, we can give them acyclovir. Generally, we only treat people who are 18 years and older. And for everyone else, we just let it run its course. Treatment will decrease the duration of disease here, but it's not really justifiable in younger children who it may have limited use for. So typically with chickenpox, we let it run its course. Even with shingles in younger people, so people who develop shingles in their 20s, we typically let that run its course. In older patients or immunocompromised patients, you're definitely going to want to treat them to decrease acute disease and prevent viremia from occurring. We can prevent it a couple of ways. One is passive antibody immunization. So a collection of antibodies that is called Varizig. So varicella zoster immunoglobulin. So we'll give this to an immunosuppressed person who maybe has a reactivation of chickenpox. Also to pregnant women, because chickenpox, like the herpes simplex viruses, can have some pretty nasty consequences if it infects a fetus. So if recurrence or a primary infection happens in either of these populations, we'll give them a bolus of immunoglobulin to help immediately control the virus. As you guys know, there is a vaccine. There's the vaccine for children, the MMRV. It's a quadrivalent in there with measles, mumps, rubella, and varicella zoster. And there's the shingles vaccine for like my parents, your grandparents. This vaccine decreases reactivation. So it's sort of a booster for your immune system so that as people age, they have more circulating antibody. So should reactivation occur, the body's better able to recognize it and prevent the virus from causing disease symptoms. Okay, we have been going for about 30 minutes or so right now. So why don't you pause here, take a break, go do something fun, or better yet, figure out what you're going to make for dinner tonight, or what you already ate for dinner tonight, and tell me what you're having. I need some new ideas for something to cook. I'm running out after 2 weeks at home. All right, so do that, take a break, come back. All right, if you're back from your break or if you're just powering through, we're going to move on to our herpes viruses that don't cause blisters. And we're going to start with human herpes virus 5, better known as human cytomegalovirus or HCMV. Again, it's herpes virus. Everything else is the same. Double-stranded DNA genome, icosahedral capsid, and an envelope derived from the host cell membrane, or host nuclear membrane, excuse me. So HCMV is actually one of the most common infections in humans. Most people have had HCMV infection and are still positive for HCMV because of its latency. It spreads really quickly through children at daycare. So parents who have not been infected before usually acquire it from their kids if their kids are in a daycare setting, because kids are gross and stick everything in their mouth. But there are a number of other ways it can be transmitted. It can be transmitted through sexual intercourse, a prenatal infection. We'll talk about this one. It can be acquired through a vaginal birth, through blood transfusions if the blood donor was HCMV positive, and even through organ transplants. So like a liver transplant with all of its nice rich blood in it, if HCMV is present in that blood, our recipient can acquire the virus as well. It can cause mononucleosis, but most often it just seems to cause childhood colds. In adults, it doesn't do much at all. And so these childhood colds, you get sneezed on by your kid, you acquire HCMV, but you most likely don't have any sort of symptoms. The population that's really, really at risk due to HCMV infections is newborns. So this is a big chart. We're going to start over here. So if we have an immune woman, a woman who's had HCMV, most of these immune women are their infants are going to be fine. So it's a very, very low percentage of previously immune women who have babies that have some sort of congenital infection. I apologize if you can hear my dog. Of these neonates who acquire a congenital infection, about 10% are going to have some sort of symptoms at birth, or they're going to have delayed symptoms. So maybe they, as they begin to age, they're missing their markers like talking and walking, and other sort of neurological symptoms may show up. So this is really, really rare in a mother who's had HCMV before. The issue now is in that susceptible population. So about 30% of women have not been infected with HCMV before. And of those susceptible women, somewhere between 30 and 40% of them will acquire human cytomegalovirus during pregnancy. So we see this really often in like a second pregnancy. So a woman has a baby, that baby's in daycare, she acquires HCMV from that first child, and there are a couple of different outcomes. So if it passes into the baby, let's start on this side, about 85 to 90% of those newborns will be asymptomatic. So it won't appear that there's anything wrong. Most of those, so 90% of those, are normal. They're going to have a normal birth, no problems, they're going to develop normally. About 10% will develop disabilities later, and usually they're neurological disabilities. So a small percentage here. Of that 10 to 15% that show symptoms at birth, only about 10% of these are going to go on to clear up these symptoms and develop normally. 90% of this cohort are going to have severe neurological complications and will never catch up and develop normally as their peers here would. Okay, so it's a very small percent, right? So out of 30%, only about 40 of those, only about 10 of those. So a very small percent of the population, but can have really severe consequences. Diagnosis is often clinical. So if a baby presents with HCMV at birth, they have these lesions like this. It gets this terrible name. It's called blueberry muffin or blueberry baby syndrome, which I think is a horrible name for I think that's a very, you know what I'm saying. It's kind of a flippant name for a terrible disease, is how I feel. But they have these lesions like this over their body. You can take these lesions, you can take blood, and you can look for HCMV DNA from your newborn. We can also take the skin scrapings or tissue scrapings and look for CPE. And what we'll often see is cells that have these are called owl eye inclusions because there are these huge inclusions here in this giant enlarged cell. I don't know what happened to the arrow. It's not quite pointing at the right word anymore. So we can treat infants who are born with HCMV. We can give them, again, an immune globulin injection. So just fill them full of antibodies that we've gotten from another source to help immediately decrease the viral load. We can give interferon therapy, acyclovir or ganciclovir. These have their own issues in newborns, right? But if your goal is to save the life and decrease long-term sequelae, that is a time when those risks might be outweighed by a need. In transplant recipients, you can give a person prophylactic antivirals. So you can give them acyclovir and ganciclovir prophylactically to prevent reactivation of HCMV in those transplant recipients, because reactivation can lead to graft versus host disease. One of the main sources of prevention is blood testing. So if a person is getting a transplant, test the transplanted organ for HCMV, then you know that you need to give a person a prophylactic drug. Also, for those of you who donate blood regularly, if you have been screened as HCMV negative, the blood donation centers will hound you asking you to donate blood again, because HCMV negative blood is safe to give to newborns and little infants who may need a transmission. You cannot give them blood that has HCV in it, because that will cause all of those same issues as acquiring the virus at birth or in utero. So blood testing has come a long way to help prevent a number of things that are caused by HCMV. Okay, moving right along. Roseola virus, also known as human herpes virus 6. It belongs to the genus Roseola virus. It's estimated that about 90% of the population has antibodies. Most of us acquire this disease as a child and show symptoms, or we get it as a teenager or as an adult and we're kind of asymptomatic. But it causes a disease called exanthum subitum, better known as roseola, which is just characterized by a pink rash on the trunk, on the face, sometimes on the upper thighs. And it's just a really common illness of kids. Usually it's accompanied by a high fever. So we get a high fever first, and then the rash. By the time the rash develops, the fever is gone. Children can also experience a sore throat or enlarged lymph nodes. But this is one of those cases where if you take your child to the doctor and they look at your child and say, oh, it's roseola, go home, it'll clear up on its own in a few days. And it does. So if it's during that time of fever, you can give your child some Tylenol, some ibuprofen. Once that fever's gone, the rash is there, but it's not really itchy. So children just get over it. But it's a really common childhood rash. Okay, so we're back now to our case study. Our college student who had a sore throat, high fever, and a skin rash. So our patient was suffering from mononucleosis. I hope you got that one. Usually when we think of mono, we tend to think of extreme tiredness. That usually comes after the sore throat, high fever, and skin rash. So usually there's a sort of a cold first, and then a few weeks later, our patient will develop that tiredness that we think of when we think of mono. How is it contracted? Well, we all know mono is also called the kissing disease. There's usually outbreaks of mono in the dorms every year. But it's not just spread through physical contact. It's also really easily spread by drinking after someone who has mono or sharing food with someone who has mono. So, yet another reason not to eat or drink after other people. Just don't do it. It's gross. So mono can be caused by HCMV, which we just talked about, but most of the time it's actually caused by Epstein-Barr virus, human herpes virus 4, also called EBV, Epstein-Barr virus. This one is transmitted primarily by saliva, and it can cause a variety of diseases, most of which we don't see very often. And it kind of also depends on the state of our person's immune system. So down here, if our person has a really, really good immune system, it's really vigorous and maybe a little overreactive, our patient will develop infectious mononucleosis. For most people, most normal, healthy people who don't either have a poor or overactive immune response to EBV, they're asymptomatic. There's not even really a cold associated with it. They just have the virus, gets into their body, and it goes into a latent state. We can see some strange diseases with EBV. Burkitt's lymphoma, right? So we have this tumor occurring here, this lymphoma occurring here. This is mostly seen in sub-Saharan Africa. We don't see this much in the United States. It can cause nasopharyngeal cancers, and it's linked to chronic fatigue syndrome. There's a lot of really sketchy data surrounding chronic fatigue syndrome, but we do know that particularly with mono, patients can be really, really fatigued, and that fatigue can last anywhere from 2 weeks up to 6 months, just depending on a variety of things to do with our patient. And then the other disease it can cause is particularly in immunocompromised patients is oral hairy leukoplakia, which is this kind of, I don't even know how to describe it, these weird protrusions on the bottom of the tongue here. I guess they're described as hairy, where its name comes from here. Okay, so a lot of different types of diseases. The one we tend to see the most in the United States is infectious mononucleosis, right? So transmitted by saliva, the kissing disease. Once the virus gets into your body, viremia occurs. So it spreads through your blood relatively quickly because the virus is infecting B cells. So once these B cells get infected, the virus actually causes them to start proliferating. And as these viruses proliferate, they are making more Epstein-Barr virus, and mono occurs because of the immune response to these infected and proliferating B cells. So the B cells are activated and proliferating. They're causing a CTL response, excuse me, and they're also causing an increase in T cells, right? So activated B cells, we're getting an increase in T cells. These T cells, the CTLs, are going to target B cells that are expressing viral antigens, and they're going to kill them. So as a result of inflammation, as a result of excuse me, proliferation of our B cells and our T cells, our person experiences sore throat, lethargy, and those symptoms that we think of when we think about mono. So diagnosing mono, there's a couple of different ways that we can do it. Often clinically characteristic signs like that sore throat, or if a person comes in with extreme lethargy and they say, oh yeah, I had a sore throat and a mild cold a couple of weeks ago, you will want to then test for EBV and for mono. So to do that test, you can do a blood test, look for IgM or IgG, excuse me, that recognizes the viral capsid. What's up, buddy? No. Can you head out, please? I'm almost done. Excuse me. So you can look for antibodies specific to Epstein-Barr. You can also look for those atypical lymphocytes that we saw in the other slide. These are called Downey cells. Okay, so Downey cells, atypical lymphocytes that are not the right shape, that have these huge enlarged nuclei perforated with holes. And another thing that can be done is looking for the presence of heterophile antibodies. So this is called an agglutination test. I believe it's also called the monospot test, which we see down here. So these antibodies are weird, okay? So your body makes these antibodies, but they're not specific to Epstein-Barr. For some reason, infection with Epstein-Barr induces the production of antibodies that recognize and cause the agglutination of animal red blood cells, usually sheep or horse red blood cells. So you can take red blood cells, you can mix it with antibody with serum that you've taken from a patient, and you look for agglutination or the falling out of these specific red blood cells or the antigens associated with those red blood cells. Very weird, right? Heterophile antibody. This is still used, even though we have some different ways to do it. This is still used from time to time to diagnose active disease. And then treatment, there's There's treatment for Burkitt's lymphoma, right? So you could give a person the appropriate chemotherapy. Again, we don't see that disease really in the U.S. For mono, you just relieve the symptoms, right? So if you've ever had mono or known someone who had mono, they're told to just rest, right? Don't do anything strenuous, rest, stay hydrated, sleep a lot, and it'll clear on its own. If you're feeling headaches, sore throat, maybe you take some sort of painkillers for it. But really, there's no good treatment for Epstein-Barr. So mostly it's just like, well, you have it, wait until your symptoms resolve. All right, next up, Adenovirus, the adenoviruses. I spent 5 years studying this virus for my PhD. My dissertation is all on it. I'm going to tell you everything you need to know about it in one slide. Here's what it looks like. It's really cool. It's non-enveloped. It has a linear double-stranded DNA genome. So again, it's Baltimore class 1. It has a naked icosahedral capsid. Here's its capsid. No envelope, that's what naked means, but has these big spikes that project from each of the vertices of its capsid. So it's really cool looking. These don't show up very well on electron micrographs. So down here's our capsid, but you can't really see those. You can't really see those spikes pointing out. They're too skinny. This one is spread again by respiratory droplets, so coughing and sneezing, and it causes a lot of respiratory infections. So anytime you've gone to the doctor with sneezing, a sore throat, a cough, and your doctor says, you're negative for flu, it's some sort of virus, it could have very well been an adenovirus. It can also cause gastrointestinal tract infections in children, so cause non-bacterial diarrhea. In the eye, it causes conjunctivitis and keratitis. It's one of the most common causes of viral pink eye every year in the United States. So it can cause a lot of things, all of which are pretty self-limiting and will clear up on their own. People who are most at risk are those who live in close quarters. So adenovirus is also, it gets this name of barracks disease because it spreads really quickly through military barracks where everyone is living in very close quarters and sharing all of the same spaces. But again, it's self-limiting. There is a vaccine for it, but because it's not a really severe infection in the general population, that vaccine is not widely used. It has been used from time to time for the military, so it was for a long time, and then they stopped using it in, I believe, the mid-90s or so. A few years ago, they started using it again. I'm not sure if they're currently using it in military personnel or not, but you'd see outbreaks of it like in basic training and those sorts of situations. So there you go. All you need to know about adenovirus, despite me spending 5 years studying it. Okay, parvoviruses. You've probably all heard of parvo if you have a pet, particularly if you have a dog. This is not that parvo. Parvoviruses are very super duper small. Again, they're naked, so they don't have an envelope, and they have an icosahedral capsid. Their genome is single-stranded DNA. Again, I apologize about the dog if you can hear him. And sorry, so they have a single-stranded DNA genome. They have a capsid and no envelope. Their DNA genome is really tiny. Look, it's only about 5 kilobases, not base pairs because it's single-stranded. So it's about 5,000 bases total. Single-stranded DNA genome, Baltimore class 2. And there's only one human pathogen, although there are a wide range of animal diseases that can be caused by parvoviruses. There's only one human pathogen. Okay, where's the FedEx truck?
I tried to trick you.
Yeah, you tried to trick me. Okay, head out, buddy. I'm almost done. So that one human pathogen is called Parvovirus B19. And it causes a common childhood infection called erythema infectiosum, also called slapped cheek syndrome, because here's what our child looks like who has it. You see how red his cheeks are, as if he's been slapped on the cheeks. And it's also called, you'll hear it called fifth disease, which is a dumb name, but it refers to this being the 5th childhood exanthem, so the 5th childhood rash that's common in kids. This infection rarely happens in adults, and when it does happen in adults, we don't get the same thing. It's actually more similar to rheumatoid arthritis. So if we look over at our timeline here, viremia, or virus throughout the body and in the blood, usually happens about 5 days post-exposure. And the first set of symptoms is going to be sort of flu-like symptoms. So coughing, runny nose, runny eyes, high fever. Those are going to decrease here at about 12 or so days after initial exposure. And then, like with Varroa virus, the rash develops after this initial set of symptoms goes away. In adults, that's when our arthritis might set in instead of our rash. We can diagnose it at any time during this by a PCR test. You could look for specific antibodies as well. But usually this one is also really self-limiting. So when a parent brings in a child and you see this sort of bright red cheek, maybe you'll do a PCR test just to be sure, but you'll say, go back home, the rash will clear up on its own in anywhere from 5 to 10 days, usually. Okay, and our last of our DNA viruses, hepatitis B. Hepatitis B is arguably the weirdest virus that we know of. It's one of those where the more you learn about it, the more you scratch your head and say, how in the world did this process evolve? It makes no sense and it's very convoluted. So hepatitis B belongs to the Hepatidoviridae family, the orthohepatinovirus genus, and it's the only member of that family or genus. It has, as you can see down here, a partially double-stranded, gapped DNA circular genome with a 5' RNA attached to it. It is the only member that we know of as a human pathogen that belongs to Baltimore class 7. So this weird genome is surrounded by an icosahedral capsid that is then enveloped. And these surface antigens on the envelope are immunodominant. That's what our immune system recognizes and mounts a response to. And we can use antibodies to these surface antigens as a really, really good diagnostic to help us determine whether our patient has chronic or acute HBV infection. So this weird genome, one of the really interesting things about it is that this 5' RNA is initially used as a primer for a reverse transcription step. So here we take this RNA, we make an RNA here, we reverse transcribe that to DNA, and then we have our double-stranded DNA genome. Where this differs from other retroviruses is that hepatitis B DNA does not integrate. So our true retroviruses like HIV undergo reverse transcription and integrate. Hepatitis B does not integrate into the host genome, even though it has a reverse transcription step. All right, so as you guys probably know, hepatitis B is bloodborne, so we can see hepatitis B infections in people who are IV drug users occasionally. It used to be a problem where we would see hepatitis B infection from blood transfusions, but we screen for that now. Most of the time it is sexually transmitted, so about 50% of US cases come from sexual transmission. It can be transmitted from mother to child, in which case the child's going to become a chronic carrier. And the signs and symptoms of disease are similar among all of the hepatitis viruses. So fatigue, nausea, anorexia, abdominal pain, arthritis, and then the big one being jaundice as the liver dysfunction is occurring. Another one that we tend to see with hepatitis B is dark urine and clay-colored stools. So this slide shows us the different paths that hepatitis B infection can take. So that initial acute infection, about 90% of children who are infected are going to move on to chronic disease. Somewhere around 5% of immunocompetent adults progress to chronic disease. The rest of those are going to clear the virus and be fine. If it develops chronic infection, a lot of those are going to become inactive carriers. So they're not going to have any sort of long-term issues. If a chronic infection goes on to something else, there are a couple of different outcomes. Our chronically infected person can immediately, well, within a number of years, go on to develop hepatocellular carcinoma due to hepatitis B infection. But that's a low percent, 5 to 10%. Most of these who have a chronic infection are going to develop cirrhosis. And cirrhosis has a couple of different outcomes. It can progress to hepatocellular carcinoma or more likely to liver failure and decompensation. So with either of these outcomes, hepatocellular carcinoma or liver failure, the only sure cure is a transplant. So if a person receives a transplant, they may go on to be fine and be okay and live a normal life. If they don't receive a transplant, the likely outcome at some point in the future is death for our patient due to liver failure. So we can see our little stat here. I don't know how up to date this is anymore. This slide's a few years old. Is that chronic HBV is the 6th leading cause of liver transplantation in the United States. Okay, so hepatitis B can be diagnosed based largely off of the sequence of antibody appearance. So not only are we looking for IgM and IgA, but we're looking for which viral antigens those are too. And there's a lot of complicated graphs. There's some in your book that show it really well. I'm not concerned about you memorizing which antibody type and which antibody target. But we can use serology to determine whether you have acute infection or a chronic infection. We can also look at DNA levels, hepatitis B DNA levels, and this will tell us whether our person is developing hepatocellular carcinoma or whether they're in the acute or chronic stage. And we can look for the presence of antigen in blood over time. So there are different antigens. You'll hear about hepatitis core antigen. You'll hear about hepatitis E antigen, so that's the envelope antigen, or a part of the envelope antigen. Hepatitis B surface antigen, that's the main envelope glycoprotein. So all of these appear in the blood at different times, and that again can help us determine whether it's an acute or a chronic disease. Unfortunately, there's not a specific treatment for acute Hep B. We don't have a really good drug to get rid of the acute stage, but we do have drugs that will help manage the chronic stage of infection. So we can treat our person with interferons, which again are going to decrease viral replication. We can use nucleoside analogs, and again, these are going to reduce the viral load, but neither of these work to clear the virus from the body. So they don't completely get rid of it, they just reduce the amount that we see in the body. We can also treat with reverse transcriptase inhibitors because, again, this undergoes a reverse transcriptase step. However, remember that the DNA from this one does not integrate into the cell. So these reverse transcriptase inhibitors are going to, again, reduce the load, but not clear the virus from the body. Okay, so there is a vaccine. This is the hepatitis B surface antigen protein. It's one of the immunodominant proteins. It's a pretty effective vaccine. And some other things we do to prevent spread right now, we screen blood donors. If a person donates blood and it has hepatitis B in it, that blood's just going to get thrown out. We're not going to give it to anyone. And we'll screen pregnant women so that they don't pass it on in utero, or if they do pass it on in utero, we know to watch the child after birth and make sure that there's no long-term consequences there. All right? So that's all, guys. That's a lot of DNA viruses. The next one that I'm going to record and put up will be on RNA viruses. And after that, we get to move on to fungi and protozoans and non-viral, non-bacterial parasites. All right? Have a great day, everyone. And I hope to see you in office hours, even if you're just coming by to say hi.